Assalamu alaikum. Good morning. Thank you for the kind invitation. Thank you for the kind introduction. My name is Munira Altarrah. I'm a consultant hepatologist and head of the GI unit in MI Hospital, and it's my pleasure today to talk about when it's not HRS, cardiorenal versus hepatorenal dysfunction in cirrhosis. I have no disclosures, and today I'm going to start off with if you have a case of ascites, decompensated cirrhosis with ascites and no signs of sepsis, and no previous known renal disease. And the creatinine is rising, and after albumin, there's no improvement. The patient is overloaded, and you have hypoxemia, and the patient is congested. So my question is, who would you call next, the nephrologist or the cardiologist? So why this talk matters? HRS and AKI is frequently overdiagnosed, and albumin non-response does not equal to HRS. And the misclassification leads to iatrogenic harm. So today I'm going to talk about the definition, the mimickers, and the cardiac disease related to cirrhosis, and the management and recommendation. And what am I arguing today is that in real practice, AKI in cirrhosis is often a mixed physiology, and cardiac dysfunction and congestion are common blind spots to us hepatologists. So the traditional views of HRS is functional renal failure, there's no intrinsic kidney disease, and splanchnic vasodilation results in renal vasoconstriction and diagnosis of exclusion. However, in this pathophysiology, if I can re-emphasize that the intrahepatic resistance in the liver increases portal blood flow, causes splanchnic vasodilatation, stresses nitric oxide and prostaglandin, stresses the circulation, affecting peripheral vasodilatation, decreasing the peripheral vascular resistance, increasing the cardiac output, triggering the renin-angiotensin system, increasing the sympathetic nervous system, and then ultimately it stresses the kidney, sodium retention, renal vasoconstriction, decreases renal blood flow, and hepatorenal syndrome happens. So what's unchanged? What's changed is the updated definition. Previously, we used to have HRS1 and HRS2, and now it's HRS AKI and HRS non-AKI. And the cutoff is less than 3 months and more than 3 months. And it remains a clinical exclusionary diagnosis, but however, if I can emphasize, it's phenotype-based evaluation. So, as I previously said, the HRS1 was now replaced with HRS AKI. There's an increase in serum creatinine of more than 0.3 milligrams per deciliter in the first 48 hours, or an increase in the 50% in the first 3 months. There is no response after volume expansion with albumin. There is cirrhosis in ascites. There's absence of shock, no current or recent use of nephrotoxic drugs, absence of parenchymal kidney disease. And then the HRS2 has been replaced with HRS AKI and split into less than 3 months, if it's called AKD, and more than 3 months CKD. And again, there's an increase in baseline creatinine of more than less than 50% in the first 3 months, with an eGFR of less than 60, and no other cause of kidney disease, and cirrhosis with the presence of ascites. HRS CKD is that the GFR is less than 60, no other cause of kidney disease, and cirrhosis with ascites. Now, the core problem is HRS is a wastebasket diagnosis. As soon as we say albumin non-response does not automatically mean HRS. Congestion or low output states can look hemodynamically stable. There's a high prevalence of cardiac dysfunction, systemic inflammation, alters physiology. AKI often is multifactorial, and HRS label may obscure true pathology. So AKI exists in a continuum, and there are mimickers that we all should be aware of. So HRS mimickers, common not HRS diagnosis in cirrhosis, hypovolemic prerenal, sepsis, and AKI is actually the most common trigger in decompensated cirrhosis. And there is ATN, ischemia, nephrotoxins, and sepsis. And why we can miss it, because the FeNA in the urine, sodium, can be misleading in cirrhosis. And cardiorenal, hepatocardiorenal, low output congestion is the main topic of today. Abdominal compartment physiology, tense ascites, high intra-abdominal pressure, decreases blood flow to the kidney, and however, paracentesis will help us guide what type of issue we have. Bile calcinephropathy is actually under-recognized cause of AKI, and which cause the bile actually causes tubular obstruction, leading to toxicity, and that can also confuse us with HRS as well. So the core of the talk is the hepatic cardiorenal syndrome, where we have an issue between the heart and the kidney, and with the liver in the background causing all this problem. So if I can explain in this busy slide that the albumin-resistant AKI, that is not classic for HRS, the liver cirrhosis produces lots of serials of inflammation triggers that causes an effect on the renal dysfunction through the RAS activation. And the cardiomyopathy reduces the stroke volume, low cardiac output, and liver and the LV systolic and diastolic dysfunction increases the stroke the SVR. So high cardiac output and progression to hepatorenal syndrome. And you can see that this is actually a triad. Each organ affects the other and makes the condition worse. So when you have a renal dysfunction driven by cardiac failure, the impaired forward flow or the venous congestion, there's neurohormonal activation from the kidney and the liver, and it is not does not respond to volume expansion. So by contrast, classic HRS is low SVR and effective hypovolemia, causes renal vasoconstriction. However, cardiorenal is low forward flow or venous congestion, which causes impaired renal perfusion gradient. Now, cirrhotic cardiomyopathy is blunted systolic and diastolic reserve, chronotropic incompetence, and stress-induced failure, and often clinically silent. So venous congestion is the missing vital signs to us. An elevated CVP reduces renal perfusion, renal venous hypertension, and ascites worsen intra-abdominal pressure. So the clinical clue against pure HRS, when we have pulmonary edema or rising oxygen requirement, pleural effusions, high JVP, or IVC dilatation, worsening renal function after albumin perfusion. Do you use pro-BNP? And we have to use it with caution. Often it's elevated in cirrhosis. Marked or rising levels suggest cardiac contribution, and trends are more informative than absolute values, so use it with caution. The slides are missing. Okay, so in this slide with the missing table, we just have to improvise here. So the management was the management of the AASLD guided management between what preference would we use and what's the correct algorithm in terms of managing HRS. So the first option would be albumin expansion. If there is no response and you made sure that there's no contributing factors, like there's no nephrotoxins, there's no sepsis, there's no other, let's say, other related like renal parenchymal disease, then you will go for the albumin expansion. There's no response, then you will go and you give the patient, let's say, a vasoconstrictor like terlipressin. So then what happens is that if there's terlipressin was given and there's no response, we should reconsider, so if the first modality AASLD guides us to that we give terlipressin. And then in the terlipressin group, there is a slight improvement compared to placebo. However, there is a response and we should use it with caution. The second option would be giving the patient a norepinephrine. And giving norepinephrine with terlipressin causes more complications and side effects compared to norepinephrine alone. However, the combined effect will have a better outcome in HRS. And the third option would be using Munira and terlipressin combined as well, has more side effects, however, has better response with HRS. So now where albumin can cause harm. So albumin non-response does not confirm HRS, and a congested phenotype worsens with volume. So if oxygenation worsens, reassess the diagnosis. Do not give the patient another, let's say, a trial of albumin expansion. Terlipressin by itself is not benign, and I mentioned that it does cause a lot of complications and side effects. It increases the afterload, may reduce cardiac output. It's associated with respiratory failure. It causes cardiac, mesenteric, and peripheral vasoconstriction. So use terlipressin with caution. Again, so phenotype, first approach. Does this patient have hypovolemia? Is this sepsis or ATN? Is this cardiorenal or is it congestive? The role of POCUS in echocardiography is you need to use it to check the IVC size and the collapsibility, the lung B lines and effusions, and basic LV and RV function. So back to our case, where albumin-resistant AKI, decompensated cirrhosis with ascites and a rising creatinine, and after albumin, hypoxemia and congestion. And my answer would be, I would call the cardiologist. They'll need to do a bedside echo, and then this patient had diastolic dysfunction, and this is how we will manage the patient instead of escalating to terlipressin and considering RCT. So why does this matter for transplant? AKI trajectory affects candidacy. Cardiac dysfunction impacts outcomes. Early phenotyping guides combined liver kidney transplant decisions. So not all AKI in cirrhosis is HRS. Cardiorenal physiology is common. Albumin non-response is not diagnostic, and misuse causes harm. This is my closing slide. However, because I've noticed some of my slides are missing, I just want to mention about pitfalls when it comes to hepatology. When we do give the volume expanders and you see that your patient does not respond, here it's a time for you to think the phenotype. Is this pure HRS, or do I need to dig in for more for other reasons? And instead of escalating treatment, it's worthwhile to get the patient investigated for other reasons. The other thing is that some patients ultimately are HRS, and ultimately they do not respond, and ultimately you will need to list them for transplantation. And today's main purpose is that HRS is overdiagnosed. Just keep in your mind that there might be other causes not related to purely HRS. Thank you so much.